My name is Terry. I'm one of the nurse practitioners with the heart failure team. I've been here for about 12 and a half years. You've probably seen me rotating inpatient with the other APPs. So please, even if you see us on the floor, feel free to ask us. We're going to talk about heart failure today, go through a few case studies, pathophysiology, everyone's favorite, and then management. So, okay, objectives, as I said, talking heart failure diagnostics, exam of a patient, treatment guidelines, and inpatient management. So just a little bit of stats. About 6.5 million adults have heart failure. Heart failure was a contributing cause of 1 in 8 deaths in 2017. And in 2012, it cost the United States $30.7 billion. And that's in healthcare costs, hospitalizations, lost wages, and even caregivers having to quit working to help take care of loved ones. Heart failure in and of itself is not a medical diagnosis. Heart failure is a syndrome. So the definition of heart failure, it's a syndrome caused by cardiac dysfunction. It results in the loss of myocardial muscle dysfunction or loss of squeeze. It's either seen by a dilated left ventricle or a hypertrophied left ventricle, or you can see both. Basically, because of this, the heart is unable to sufficiently pump blood to meet the needs of the body. When we talk about the medical diagnosis, and you'll see these in our charts and documentation, you're either talking about systolic or diastolic heart failure. So systolic heart failure is caused by a reduction in the left ventricle being able to squeeze blood, and you will see a reduction in the ejection fraction. And normally on echo, you'll see that this heart is dilated. A diastolic dysfunction is characterized by the decrease in relaxation of the heart. So you end up with a stiff ventricle and the heart doesn't relax, which means it can't fill, and then it can't squeeze blood. Normally, if you have just diastolic heart failure, you have a preserved ejection fraction, but you can also have systolic and diastolic heart failure. This is just a picture just so you can kind of understand the difference. The picture in the middle is a normal left ventricle. The picture on your left is systolic heart failure, where the heart is dilated out and doesn't squeeze well. And the picture on the right is where the walls of the heart are thick. So even though you have a normal percentage squeezed out, it doesn't relax and doesn't allow for the ventricle to fill. When we talk about heart failure, we always want to look for the causes of the heart failure to see if there's anything that is reversible. Heart failure with reduced ejection fraction, the main cause is ischemia. 2/3 of all cases of heart failure, HFrEF, are caused by ischemia. And those are obviously the easiest to find and determine through stress testing and heart cath. Other causes are a little more difficult to tease out. A lot of our patients end up being just called non-ischemic cardiomyopathies, and all of these other ones fall into that, whether it's a virus, a familial cardiomyopathy, you can have tachycardia-induced cardiomyopathy from uncontrolled atrial fibrillation. You can have cardiomyopathy due to untreated hypothyroidism. We had a patient here, this was a long time ago, but had such severely profound hypothyroidism, ended up needing an LVAD. Toxins in our patient population are pretty common for causing cardiomyopathies. Toxins are illegal drugs, alcohol, and even some of the medications that we give are considered cardiotoxic. Adriamycin is one of the most common, but there's also some other medications, rheumatoid arthritis, that can cause that. Peripartum and postpartum is the most treatable non-ischemic cardiomyopathy. Once the baby is born, if you tell the person that they should not have another child, very likely their cardiomyopathy will not come back and they will regain function. Adult congenital heart disease is another cause of HFrEF. I'm not really going to talk about that today, but we have a ACHD team here, and they take care for most of those patients, and later in life, because they're surviving much longer, they end up with systolic heart failure. Most common causes of HFpEF are hypertension, valvular heart disease, constrictive diseases such as radiation, constrictive pericarditis, and then infiltrative diseases such as sarcoidosis or amyloidosis. Just a quick look at heart failure pathophysiology. I know no one loves pathophysiology, but within cardiology, the pathophysiology of heart failure is very important because these are where we target all our medications. When a patient has cardiac injury, the body's natural response is to activate your sympathetic and parasympathetic nervous system. They do this to increase cardiac output, thereby increasing end organ oxygenation. And when you first have heart failure, this is good. This helps perfusion, this helps control your blood pressure. But over time, this causes the left ventricle to negatively remodel, to dilate, and to actually become harmful to the body. So we look at all of these medications and target these different areas to prevent, to help prevent the further remodeling and try to improve their overall function. When you look at heart failure, the AHA and and HFSA are two organizations, and they look at how to classify heart failure. The American Heart Association does this by staging. They look at both structure and symptoms. The New York Heart Association functional class for heart failure is class 1 through 4, and it is truly symptom based. So you can have a patient that one day is stage 4 because they can't even do anything at rest, and when you've got them on meds and treat them 2 days later, they're a class 2 to 3, but based on the structure of echo, they would remain probably a class C or D. And when you look at here, putting those two together, increasing severity, most of the people that you see on the advanced heart failure service are probably a C or D, class 3 or class 4. Those are the patients that are frequently rehospitalized. A lot of the patients that are first diagnosis admitted to the hospital are probably a stage B or C in that class 1 to 2, depending on how you can get them. When we first see a patient that we suspect they have heart failure, first you want to assess for severity. You need to look at cardiac structure and function, which is an echocardiogram, or as Dr. Syed, I caught the end of his talk, talking about cardiac MRI or even CT. We don't use CT very often because we're not really interested in vessels. We're more interested in myocardiogram, which the MRI gives you a much better view of. Then we want to determine what the cause is for sure. If we think they have ischemia, we need to take them to the cath lab and see what can be reversed. We need to see if there are any arrhythmias that need to be treated, see if there's any exacerbating factors that we can help with, identify comorbidities. Upwards of probably 40% of patients who have heart failure also have obstructive sleep apnea. So it's very important to treat for that, to treat high blood pressure, to treat diabetes and all these other things, because they all work together. And then to look for any potential treatment barriers on the inpatient side. We rely heavily on case management and social work to look at our patients to say, do you have your insurance? Are you going to be able to get your medicines? Do we need to get you set up with financial assistance so that when they leave, they aren't back in 2 weeks because we sent them out, but they only had a week's worth of their diuretics and now they're in trouble again. I like to use this as a simple way to look at your patients when you're talking about them in the hospital. So this is the Forrester classification, and it helps us look at perfusion and congestion. Perfusion is basically your blood pressure. Do you have warm extremities? Do you have a normal blood pressure? Or are you altered? Do you have an altered mental status? Do you have decreased urine output? Are your extremities cool? And then we look at congestion? Do you have JVD? Do you have hepatojugular reflex? Do you have rales? Do you have ascites or anasarca? Patients, we like to keep them warm and dry. That is your well-perfused, not fluid overloaded patient. A warm, I don't know if I put, nope, sorry, I didn't put the treatments in here. A warm and wet patient, it's probably the easiest heart failure patient to treat because you can just diurese them and they should get better. Cold and wet are sometimes easy to treat, sometimes not, because they're not being well perfused. So those are the patients who normally come from the cath lab that we start on dobutamine or milrinone to get some inotropic support, and then we put them on a Lasix drip. Those are also probably the patients that, those are the subset of patients we're looking at. Are you an LVAD or transplant candidate? And then your cold and dry are definitely your end stage patients that inotropes are what you're looking at. They obviously don't need diurese. These are also the patients that you're looking at LVAD and transplant on. This here, just looking at hemodynamics. If you have a patient who's warm and dry, you have a wedge of around 15 and your cardiac index is greater than 2.2, all the way down to cold and dry, where your wedge is normal and your cardiac output's less than 2.2. And I already talked about this, sorry. So here, warm and dry, good job. Warm and wet diurese, cold and dry inotropes, or do they need volume? And I'm going to tell you, we never give our heart failure patients volume. So inotropes, and cold and wet inotropes diurese. So this is the first case study I put in here. It's a 48-year-old gentleman that we actually took care of probably 7 years ago now, maybe even longer. Presented to his local emergency room with shortness of breath, cough, and fatigue times 1 month. Cannot walk around his house without getting short of breath and tired. He hasn't seen, he doesn't have any past medical history, and he hasn't seen a primary care in over a year because he's a 48-year-old man and doesn't feel like he needs to see the doctor. His dad died of a heart attack in his 60s. Social, he's single. He smokes 2 packs a day, but for the last week or so, he's been too short of breath to go outside to smoke, which to me is a telltale sign that this patient's not doing well and is in trouble. On admission, his physical exam, he's hypertensive. He has coarse lung sounds. He has 1 to 2 lower edema, and he's not hypoxic, but not statting normally. His chest x-ray shows bilateral infiltrates and an enlarged cardiac silhouette. His labs show he has a normal, slightly elevated white blood cell count, hemoglobin, hematocrit normal, potassium is normal, his BUN and creatinine are elevated. So as you are not going to answer, I will give you the what do you think. So this is a new patient who's hypertensive, fluid overloaded, and chest x-ray is abnormal. Testing further to recommend probably a lactic acid. Procalcitonin at the time wasn't really used that often, but now we would order that. And then to treat the patient, locally he was treated for pneumonia. He was treated for started on medications for his blood pressure, and he was transferred to Nebraska Medicine. This was a small hospital in Iowa, and they felt potentially he had something more going on, so wanted him transferred and treated for further management. His vitals on transfer shows blood pressure still in the 160s to 180s. He was short of breath with a cough, had 2 to 3 plus lower extremity edema, still had the JVD and hepatojugular reflex. Current meds he came on were Lasix 40 milligrams IV, Coreg 25 BID, and lisinopril 20. Do you guys have any thoughts of what we would do now? So of course we echoed him. His echo showed his EF of 5 to 10% with biventricular failure, mild mitral regurgitation, which was secondary from his dilated LV, and pulmonary pressures of 40 to 45. Is there any changes that anyone could, I'll give you a second to think about changes you'd want to make. So we decreased his beta blocker, we continued his IV diuretics, and we added hydralazine and IMDR. When you have a patient that's newly diagnosed with heart failure, you should not have them on beta blockers because it could worsen their output and send them into cardiogenic shock. We didn't stop it because he had been on it for a couple of days and was tolerated, but we lowered this. And we added hydralazine and IMDR for afterload reduction. We felt that where his creatinine was, we wanted to try to further afterload reduce him with those elevated pulmonary pressures and see how it went. We then discussed different ways to look at his heart function to assess for ischemia, as he clearly smoked 2 packs a day and has family history of coronary disease. His creatinine never really improved beyond 1.6 to 1.7, so we decided not to perform a heart catheterization. He underwent an adenosine MRI after he was diuresed, and this showed hypertrophied left ventricle with EF improved to 40%, mildly dilated RV with normal function. It was negative for ischemia. After diuresing him, his ejection fraction improved, and looking at his MRI, it was felt that he likely had a hypertensive cardiomyopathy and had long-standing untreated hypertension. Our typical follow-up for all of these patients is they see APP in clinic in 1 week, and then in 1 month they see their cardiologist. We try to make sure that we have them set up before they leave so that we can ensure that they're going to come. That first visit, we like to make sure that they're taking their medicines, they have them all filled, that their fluid status is maintained, because while they're in the hospital, we can watch their ins and outs very closely. And as soon as they leave the hospital, you don't get that. Now, just talking about heart failure treatment in general, the goals of treatment are to improve symptoms and quality of life, to slow the progression of or reverse the cardiac remodeling, and to reduce mortality. We have non-pharmacological treatments and pharmacological treatments, along with device therapy and end-of-life measures with our palliative care team. So non-pharmacological treatments that you guys will see us talk about all the time: sodium restriction, fluid restriction. I'm sure it may seem like we harp quite a bit on accurate I's and O's and accurate weights, and it may seem a little silly, but I will tell you, every single day on inpatient, we look at their I and O's, we look at their weights, we compare to see if it makes sense that the amount net negative equals the amount of weight negative. And so for us, those are very important that we follow on a regular basis. Other things for these patients, you want to screen them for medical comorbidities like I talked about. You should have regular exercise. We now send all of our HFrEF patients to cardiac rehab. They have this approved and it's covered under Medicare, Medicaid, and then lifestyle modification, weight loss, regular exercise, quit smoking, decrease alcohol consumption, avoid any illegal substances. This here is a heart failure treatment algorithm. I'll tell you, if you have a patient that's in the hospital for a heart failure exacerbation, they're going to be started on guideline-directed medical therapy and then reevaluated in 3 to 4 months to ensure that their function has improved. Otherwise, they're getting looked at for ICD therapy. This is our next case study. It's a 65-year-old gentleman who has a past medical history of severe coronary disease. He's had a CABG in 1984. Hypertension, hyperlipidemia, and diabetes, and he has developed an ischemic cardiomyopathy. His last echo shows his EF to be 15%. He presents to the clinic with increased shortness of breath, lower extremity edema, and fatigue. He can only walk from the living room to the kitchen before stopping, but if he sits in his chair, he doesn't feel as short of breath. His physical exam shows his blood pressure to be stable. He's tachycardic, he's tachypneic, and his SATs are a little low, but he's not hypoxic. He has JVD to his mandible, he has rales, he has a systolic murmur at the apex, and he has a hepatojugular reflex. So this patient's being directly admitted from clinic. What orders do you expect to see? So I would say that he's adequately perfused. We would consider him warm and wet, so you're going to see him being diuresed. So his labs, when he came in, shows H&H, stable BN and creatinine, elevated, but honestly stable for most of our patients. His AST and ALT are mildly elevated, and his bili's elevated. His chest X-ray shows cardiomegaly with a small right pleural effusion. His EKG shows sinus tach, which is unchanged. His EF shows his echo shows an EF of 10% with LV severely dilated and decreased systolic function, and his RV is severely decreased systolic function. He now has severe mitral regurgitation. He has biatrial enlargement. So NYHA functional class, he is a class 3 because he is symptomatic with any activity but not at rest. AHA stage is a C or D. So like I talked before, this is a patient who's going to be diuresed to see if his function gets better. He's also someone that we're probably going to be looking at for advanced heart failure therapies. So now just talking about pharmacological treatments, the medication classes that we talk about, all that fall under guideline-directed medical therapy, are ACE inhibitors, our ARBs or our ARNIs, our beta blockers, aldosterone antagonists, that is spelled wrong, I will fix that, sorry, vasodilators, diuretics, and SGLT2 inhibitors that are the most recent class of medications approved for heart failure patients. And this is a caveat, all of these medications are approved for patients with HFrEF. To date, there is little medical therapy that has been proven to improve patients with HFpEF, and most of these patients end up with you treating the underlying medical comorbidities and diuresing them. So ACE inhibitors, ARBs, and ARNIs, which is the newest medication in this class, sacubitril valsartan, also known as Entresto. All of these medicines work along the renin-angiotensin-aldosterone system. The difference in the ARNI is that it also works along the neprilysin system, works with vasoactive peptides, all of which then are cardioprotective and aid in a little bit of diuresis compared to the other two. All the studies have shown that they reduce mortality, reduce hospital admissions, and they improve cardiac remodeling. The side effects are angioedema, hypotension, and hyperkalemia. ACE inhibitors are the most common cause of angioedema. If you have a patient on an ACE inhibitor, they need to be off of that for 36 hours before they can be started on an ARNI for potential of angioedema. Typically, if we have an acute patient, we'll start them on hydralazine and nitrates, and then once they've stabled out, we'll switch them to ACE ARB ARNI, as these also are good at afterload reduction and some vasodilation. Beta blockers is your other class of medications that are used in all patients. The three medications that have been studied in HFrEF and have been found to be superior are bisoprolol, metoprolol succinate, which is either toprol XL or toprol ER, or carvedilol. These suppress the adrenergic nervous system, and they work on beta blockers in the heart, thereby decreasing heart rate and lowering blood pressure. This allows for more filling time in between each cardiac cycle. Patients, when started on beta blockers, will probably feel more tired for the first 2 to 3 weeks. The hemodynamic studies on beta blockers show that when first started, they will decrease your cardiac output, but after about 3 to 4 weeks, your cardiac output is actually improved before it was being on beta blockers. Side effects of beta blockers: fatigue, COPD exacerbation, and some hypotension. Beta blockers are not recommended for acutely decompensated patients. Coreg, because it has alpha and beta, carvedilol, because it has alpha and beta, will lower your blood pressure much more than the other two. So if we have patients who are hypertensive, carvedilol is a better option. But if we have patients who are a little hypotensive and more tachycardic, we normally are going to start them on some metoprolol because you can titrate that better without lowering blood pressures as much. Aldosterone antagonists are your spironolactone or your eplerenone. They block the action of aldosterone at the site of aldosterone receptors. This decreases fluid retention and has some diuresis effects. It will reduce mortality, rehospitalizations, and myocardial fibrosis. The main side effects are hyperkalemia and then gynecomastia for spironolactone. If you do have a patient who develops gynecomastia, you can flip them to eplerenone and this should go away. These are nice sometimes in patients who also need diuretics because they're potassium sparing. So we can get a patient on this and a loop diuretic and maybe not need potassium supplementation. Vasodilators are other medications. It's a combination of hydralazine and isosorbide dinitrate. The combination together dilates arterioles, decreasing afterload and preload, can also help vasodilation in the pulmonary arteries. They're more of a pain in the ass to take because it's 3 of each pills. If you're giving them to these patients, you want to make sure in an outpatient setting that these patients are compliant and willing to take them. Otherwise, they're just not going to take them. These medications have actually shown even more benefit in patients that are African American just because of better vasodilation in them. But it is not our first line outpatient therapy because the other medications have shown more benefit and this medication regimen is more difficult to adhere to. Diuretics are the cornerstone of heart failure treatment. Although they don't improve mortality, they can help decrease hospitalizations if taken right. The main diuretics we use are loop diuretics. Those are your furosemide, your torsemide, and your pumidine. There's also thiazide diuretics, your chlorthalidone and your metolazone. We typically use them as add-ons for people who are on Lasix drips or just not diuresing with their current regimen. Some of the side effects are electrolyte imbalances and hypotension, so you need to be careful when you give these to patients if their blood pressures are low to begin with. I will tell you, out of any medication that the patients will take, these are it because they recognize that it is the one that gets rid of the fluid and then they feel better. This is just a nice picture of how they actually work for you. And then the newest class of medications are SGLT2 inhibitors. These medicines were actually studied and first approved for diabetes. They decrease glucose, decrease kidney reabsorption, and decrease your overall glucose levels in your body. All diabetic medications, when studied, now have to be proven to be non-cardiotoxic. There were a few diabetic medications back in the day that had adverse events for patients with coronary disease, so they're now all studied. When they started looking at SGLT2 inhibitors, they found that not only were they safe for patients who had heart failure, but also improved outcomes for some patients with heart failure. And that is because they also work on LV function. So they can work to decrease your cardiac preload. They increase diastolic dysfunction and they can decrease afterload. The net effect of this is diuresis, which you see here, and they actually work a little bit better. So your loop diuretics work to get rid of blood volume that are actually in your vessels, whereas SGLT2 inhibitors work with interstitial volume. So if your tissues are swollen in your third spacing, these help get rid of this swelling. These medications were approved last year for patients who were diabetic and had HFrEF, and they showed such a good benefit that they actually have done further studies on patients who are not diabetic and have HFrEF and showed the same overall effects with decreased mortality, decreased hospitalizations, and decreased need of diuretics because of getting rid of intravascular volume. The medicine that was approved for this was dapagliflozin, and this was approved in May of 2020. So you may have started to see some patients on this medication in the hospital. If they've been started on this in the outpatient setting, we have not stopped this medication and we've continued it. It's non-formulary, but we've been able to get it from the outpatient pharmacy and we've continued this for our patients. These are the 3 different medications, so canagliflozin and pagliflozin and dapagliflozin. Main side effects that you would look for is hypotension and overdiuresis. So now we're going to go back to our case study of our 65-year-old with coronary disease. So he received 80 of IV Lasix overnight. He had 750 in urine output, and his BUN and creatinine are stable. So stable to a little up. So what are some things that you would think might happen? So options are start a Lasix drip, change to oral Lasix, to oral torsemide, continue the 80 of IV Lasix daily, or perform a right heart cath. So just looking at the options, yes, starting a Lasix drip is probably a good option. Changing to oral torsemide would not make sense as the patient was on an IV the night before and did not have good urine output. Also, continuing the 80 milligrams of IV Lasix doesn't make sense because what he put out last night is not enough and you would want more diuresis from that. Performing a right heart catheterization might be the right option, especially with his fluctuating kidney function. Maybe his cardiac output really is lower than we're thinking it is, even though he has adequate blood pressure. Typically, we like to wait until we know they're a little bit more euvolemic before doing a right heart catheterization. But if we're really kind of stuck, especially with a patient like this who has borderline kidney function and we're not sure which way to go, performing a right heart catheterization might be your best option. So he went and he had a right heart. So these are normals for your right heart catheterization: an RA less than 5, RV less than 25/5. Your pulmonary artery mean should be less than 25. Your wedge should be about 6 to 12, and cardiac index 2.5 to 4 is normal. But honestly, if we're 2.2, 2.3, we're doing okay. So our patient went for a heart catheterization. He had an RA of 11, PA of 55/26 with a mean of 40 and a wedge of 31. So looking at his cardiac output and cardiac index, his cardiac output was 2.54 and his index was 1.54 by FIC, and by thermal his cardiac output was 2.7 and 1.54. So this patient has low cardiac output, and the reason he's not diuresing is because he's not adequately perfusing. So I would recommend this patient be started on inotropes in addition to his Lasix drip for further diuresis. Also, with a cardiac output and cardiac index that low, that patient should be looked at for advanced heart failure therapies. I have one slide in here about device therapy. More than 80% of patients who have a ventricular arrhythmia do not survive to receive ICD therapy. All studies show that if you've been on guideline-directed medical therapy for at least 3 days or 90 months and your EF remains less than 35%, you should get an ICD. ICDs are indicated for patients post-cardiac arrest outside of a acute MI. So if you have a cardiac arrest outside of the hospital and it's not in the setting of an acute MI, EP should be called and they should have a device. NYHA class 3 or class 4 should be evaluated for BIV pacing, and that is for patients who have widened QRS. And patients with life expectancy less than 1 year should not have an ICD implanted based on current guidelines. Advanced heart failure therapies that are offered here: heart transplantation, LVAD, total artificial heart. We have not done a total artificial heart in quite a while, and I'm personally okay with that. And then we have inotropic therapy. The inotropes we currently use are dobutamine, milrinone, and we'll use dopamine inpatient. We've only sent one patient home that I can remember on dopamine. But for the most part, we can send people home on dobutamine and milrinone, either as palliative therapy, or we can send them home as a bridge to transplant on inotropes. And then many of these patients, for one reason or another, may or may not be a transplant candidate, may or may not want a transplant. So it's always important to have open discussions with these patients. They are, when we're talking about end-of-life measures and talking about their wishes, you need to talk to them about their ICD. You need to give them honest discussions about the fact that you can turn off the shocking therapies, but it will still pace them if needed to. You need to be able to involve their family members.